from the American Academy of Pediatrics.
Access to reproductive health care varies from state to state and is not always equitable.
That's why it's important for pediatricians to counsel patients about all options.
Our Bright Futures, our best practice guidelines, suggest that at well visits, pediatricians talk to young people about sexual behavior, reproductive health, reproductive goals and choices.
Plus, an analysis of pediatric research shows the need for a more multilingual approach.
The exclusion of patients and families who speak languages other than English from research exacerbates inequities that have been well demonstrated.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about contraception and birth control.
When I trained in the 90s, we learned about how to prescribe birth control pills and how they compared with condoms, other barrier methods, and IUDs. End of story. But today, there are so many more options. And as someone who sees adolescents, I find this new world exciting, but also a little confusing.
There were so many more reproductive freedoms and access in the 90s too, though, and it makes me sad that people just don't get the same education and choice that they did in the past.
That is true, and that makes it so important to let families, and especially teenagers, know what options exist and how they can access them, even when they might not be available in their own state.
We are in luck because today's guest is Dr. Mary Ott. She's a professor of global health and pediatrics and an adolescent medicine specialist at the Arnold Institute of Global Health at the Icahn School of Medicine at Mount Sinai. And while in New York City, she will be doing a lot of work internationally. She's here to talk about birth control. Dr. Ott, welcome to the show.
Thank you. I'm very excited to be here.
I think a lot of people consider contraception and birth control to mean the same thing, but there are reasons we prescribe contraceptives aside from family planning, right?
Yes, definitely. We can use contraception for menstrual disorders. Anytime someone wants to lighten up a period or suppress a period for any reason whatsoever, whether they're getting cancer treatment or whether it's just a preference, we can use contraceptive methods. They've also been licensed for use with acne, for mood regulation for young women that have mood changes and instability around periods, and for other menstrually related phenomena like menstrual headaches.
Now, my parents' generation was the first one to have access to the pill, but now there are lots of different pills. So how should we think about oral hormonal contraception today?
I think we need to think about it from a health equity perspective. You know, there's a lot of options out there, and it's the choice of birth control is really sensitive to preferences. And like a young person who's invested in a birth control method is going to be successful with it. And we want to help young people match up with a birth control method that meets their needs. So we want to think about what our own biases are and what we bring to the table. We want our counseling to be adolescent-centered. What are the young person's preferences? What are the contexts? What's access like? What are their developmental needs? And then we want to help them find a method that meets their preferences. For many adolescents, it's effectiveness. And so thinking about LARCs, the IUD or the implant ends up being really important. But for other adolescents, their most important issues are privacy. So this new over-the-counter pill, O-pill, might be a really nice option for them, something that they can use privately. For others, it's going to be side effects. They want to have regular menses or they want to treat acne. So I think really making it adolescent-centered and thinking from a health equity perspective, like how do we make this process of counseling about contraceptives really about the teen and address health inequities that exist in contraceptive access.
So you mentioned O-pill, Mary. Can you describe how that's different from traditional hormonal contraceptive methods?
Thank you for asking that question. I think O-pill is a really exciting new medication coming out. And it's really important for pediatricians to know about it because our young people will be using it. It differs from the traditional combined estrogen progestin oral contraceptive pills that many of us learned how to prescribe in residency, in that it's a progestin only pill. It has norgestrel in it. And this has really important implications for young people taking the pill and for pediatricians supporting young people. So the first is that because it's progestin only, it's really safe. There are almost no contraindications to it. There's no placebo with it. So young people get progestin hormone every single day and will not have regular periods. On the flip side, the main side effect is spotting and irregular bleeding. So again, a pediatrician will need to know to counsel about this. The other piece that's really important to know to support young people's use of O-pill is that they need to take it about the same time every day. If it's more than 3 hours off, then it's considered a late pill, and the young person should use some type of backup method, like condoms, for 48 hours. This piece of counseling will really be critical, and pediatricians are good at working with young people to think about, do I set a phone alarm? Do I take it along with another medication? So I think it's like knowing these pieces of O-pill use will be really important for pediatricians. My advice would be for pediatricians to learn about O-pill, to go into a pharmacy, to look at the packaging insert available online, and then incorporate it into your contraceptive counseling as an option and as a way to empower youth to take care of their own reproductive and sexual health.
So what is the cost of O-pill and how can teens pay for it?
So O-pill is about $20 a month, which ends up being a recurrent cost for a young person taking O-pill. And as we all know, cost can be a really huge barrier for young people. Coverage is complex. Some insurers are actually picking up the cost of O-pill, but it's something that there's currently discussion about it. And this is actually a place for pediatricians to advocate, both within their state AAP and within the national AAP, for coverage of O-pill. It is also, the cost was something that a pediatrician should talk with a young person about when they're counseling, because if the young person has an insurance plan that doesn't cover O-pill, then it may be the better part of valor might be a prescribed birth control pill, even if they're prescribing a progestin-only pill. So it's one of these factors that would be a contextual factor that we should take into account with counseling, and also keep in mind in our role of pediatricians as advocates for young people.
You've talked quite a bit about counseling, but now that O-pill is available without a prescription, teenagers might not talk to us about contraception. When and how should we make sure we still get to counsel on this?
Well, I think that it's always important for young people to discuss contraceptive options with their pediatrician. And we've been talking about over-the-counters with young people for decades, with emergency contraception and making sure young people have access and know how to use emergency contraception. We talk to them about condoms. So the O-pill is just joining our sort of suite of over-the-counter options for contraception and birth control for young people. So I would say it's always important. I mean, our Bright Futures, our best practice guidelines suggest that at well visits, pediatricians talk to young people about sexual behavior, reproductive health, reproductive goals and choices. And the O-pill is just one piece of that discussion.
Now, are you concerned that access to over-the-counter medications may vary by state? And do you know any resources that will provide methods of contraception by mail?
Yeah. So expanded access to contraception is something that has become increasingly important, both for young people and for pregnancy-capable persons across the country. Over-the-counter methods are one way to expand access. Right now, the O-pill is scheduled to be available in every state, and there's no lower age limit. It was FDA approved for all reproductive age women. But there are other ways that we've expanded access. There's pharmacist prescribing. Some states have state-specific laws. Some pharmacies have entered collaborative drug therapy management agreements with provider groups. So, and there's telehealth options. So I think that there's a lot of, and many pediatricians are actually using telehealth to prescribe contraception to young people. So we have a lot of ways that we've expanded access: over the counter, pharmacy, telehealth, app-based methods. So I think this expanded access is something that we're seeing as a way to help young people and connect young people to the contraceptives that they need.
It's so exciting to have new access to different kinds of birth control pills, but people still need to remember to take them pretty much every day. But now we also have, in addition to the injected progesterone that we've had for a long time, these hormonal implants. Can you walk us through what we should be thinking about when we prescribe these long-acting reversible contraceptives to our patients?
Yeah, I think one of the things to keep in mind is that all methods of contraception are safer than pregnancy. So, when we think about side effects, we have to think about, if they're not using a method, what does that look like? I think a piece of it is this sort of health equity framing in talking with young people about birth control. We as pediatricians will need to be familiar with all the different methods, and there are online resources for that. I will send both young people and pediatricians to decision-making tools like Bedsider. And so thinking about what are the young person's preferences? Are they focused on efficacy, in which case we really need to be thinking about long-acting methods and help and talk to them about implants and IUDs. Are they thinking about wanting to have regular periods, wanting to have privacy, and sort of gear our counseling towards what their preferences are?
So, Mary, who would you consider a LARC for, and who might benefit by taking the pill every day?
I would start with their medical conditions and see whether they have any contraindications to a particular method. LARCs tend to have very few contraindications. There are two classes of IUDs. One has levonorgestrel and the one has copper in it, and the copper has no hormones in it. The levonorgestrel is a low dose progestin. The implant has low dose progestin in it. And so thinking about do they have any medical contraindications would be my first step. Are they able to take estrogens, not able to take estrogens? And then my second step would be sort of what's their preference? For some young people, they love the idea of get it and forget it and the ease of placement of an implant. Other young people want to have no periods, where a levonorgestrel IUD would be a great choice. Other young people want to have regular periods and really want to have improvements in their acne. For them, a combined estrogen progestin method might be good, like a pill or a ring or a patch. Usually what I do is first get their sort of priorities and preferences, and then we start working down the methods and thinking what do you like about this method? What do you not like about this method? What are you realistically able to do? Some young people are I just can't take a pill every day. Other young people are I already take a pill every day. It's really easy for me. I'll just put them next to each other and take my pills every day. So I think it's really this idea that it would be person-centered, and it would be, sort of what the adolescent sees as their needs and their preferences is going to be really important. We've moved away from the most effective to least effective to more person-centered. I mean, with this idea, though, that for many, if not most young people, efficacy is super important. So knowing about and having access to long-acting methods is a really critical piece. There's also in the past, we wanted to try people on pills and then move them to LARCs. People can start with LARCs as a first line method. That can be the first thing that they do is get an IUD. And IUDs are safe in young people who have not had pregnancies. So it's not necessary for that. And we use them fairly extensively for young people with disabilities, for young people with medical conditions. They can be placed under anesthesia so young people can have a sedated IUD procedure, particularly for young people who have disabilities, and, that it's a really nice option for them.
Now, we've talked a lot about contraception so far, but we have not really talked about preventing sexually transmitted infections. When we talk to young people about contraception, what do we need to remind them about STIs and condoms?
Hormonal methods and LARCs don't protect against STIs. So young people do need to think about STI prevention. I let people know that STIs are sort of equal opportunity employers. Like, they don't care who you are or what you look like. They'll infect you if they can. And most people don't have any symptoms. So it's like, it's not your partner deliberately giving you an infection. It's your partner truly not knowing that they're infected and then causing the infection. Condoms are our mainstay as a barrier method for STIs. But I think it's also important to know that there are other things that people can do. People can get tested regularly. And we recommend yearly testing, or testing with partner changes, or testing when young people feel like they need to be tested. So testing for STIs, having a conversation with your partner, and having a discussion about it is also, communication is a really important piece of that. So I think thinking about STI treatment sort of broadly, not just sort of a barrier preventing gonorrhea or chlamydia from transmitting from person to person, but thinking about it a little bit more broadly. What are you doing in terms of testing? What are you doing in terms of disclosure? What are you doing in terms of having a conversation with your partner about contraception and sexually transmitted infections?
And when we think about sexually transmitted infections, I tend to also think about HIV. What do you tell your patients about pre-exposure prophylaxis, or PrEP, to prevent HIV?
Well, PrEP is a great tool for HIV prevention. Essentially, it's taking an antiretroviral in advance of any sexual encounters to prevent transmission. And there's both oral PrEP as well as injectable PrEP. When prescribing PrEP, it's because our epidemic in the U.S. is centered in specific populations rather than a generalized epidemic. Usually I screen young people for HIV risk, or if a young person comes and asks for PrEP, then I provide them with PrEP.
Mary, this has been a great and far-reaching conversation, but do you have any final takeaways before you leave us?
Well, in addition to learning about OPIL, I think also really having pediatricians think through, what does young people's access look like in your state? What does Medicaid cover? What proportion of young people are covered by private health insurance? What are your state laws around parental involvement in contraception? And what type of access do young people have to methods outside of the physician's office? Do they have access via pharmacy with pharmacy prescribing laws? Do they have access to over-the-counters? Do telemedicine laws in your state allow app-based access to contraception? And so thinking about knowing these contexts will help a pediatrician work with a young person in a very adolescent-centered way to find a form of contraception that works for them.
Dr. Marriott, thank you so much for talking with us today.
You're welcome. Thank you for the opportunity.
To learn more about contraceptive options, visit us at aap.org/podcast.
Coming up, we'll look at why doing research in languages other than English can improve health outcomes. All right, David, imagine you are on a bike vacation in Korea. It's all going well until you fall off your bike and break your arm. So now you're in an emergency department in a country that's culturally and linguistically very different from this one.
Oh, Joanna, I don't know if you know, but that gives me PTSD because Christy did fall and get a concussion, which may or may not have been my fault, when we were biking in Spain. And while I speak Spanish, she does not. But I'm imagining the same thing happening in Korea, and I'm trying to describe my headache and dizziness or understand the plan, and neither of us speaks Korean.
Even though we're both doctors, I feel like we'd feel a little lost having to navigate something related to medicine that wasn't in our native tongue.
It'd be so hard. And the only way it would get better is if in medicine we thought a lot harder about how we use language, particularly in scientific studies that change and guide how we practice medicine.
And that's why today we're going to talk about that with Dr. Alyssa Coffin. She's the first author of a paper in pediatrics entitled Creating Culturally Adapted Multilingual Tools for Research. She's also a pediatric hospitalist at Boston Children's Hospital and an instructor at Harvard Medical School. Dr. Coffin, welcome to the show.
Hi, thanks so much for having me.
All right, let's leave my theoretical bike accident in Korea and come back to the United States. If you don't speak English in the U.S., what is your healthcare experience like?
So unfortunately, it's been pretty well demonstrated that families and patients who speak languages other than English face worse health care outcomes in the United States. So specifically, we've seen suboptimal communication with healthcare providers. They have decreased access to care, and there's even increased adverse events for these populations. And sometimes kids are even put inappropriately in a position to interpret for their families when trying to access healthcare.
And we know research can improve healthcare experiences. How many research studies include families who don't speak English?
So a recent study showed that only 9% of pediatric research studies include any language other than English, and the majority of those only included Spanish. So this exclusion of families who use languages other than English worsens those inequities that I was just mentioning and advances the care for the patients who are included and leaves the other families behind.
And why are these families who use languages other than English excluded from research?
So we think there's probably a handful of reasons why these families are excluded. First off, just awareness and motivation by researchers. We know that there's some limitations in translation and interpretation services, limited availability of existing translated materials, time and budget required for appropriate translation. And then we think that potentially an emphasis on scientific rigor and concerns about translation validity at the expense of the feasibility of creating translated materials could contribute to not translating materials.
So in terms of addressing this problem, the World Health Organization has described some methods for translating research materials into other languages. Can you tell us a little bit about what the WHO recommends?
The WHO approach consists of a couple steps. First off, there's a forward translation, which is translating materials from the original or source language into a target language. And then they recommend an expert panel review. So this is review by bilingual individuals who are fluent both in that source and the target language and also familiar with the materials being translated. And then these translations are reviewed with participants who are representative of the ultimate target population. And finally, the WHO approach recommends an independent back translation by translators who were not previously involved in the process. They do overall recommend a focus on conceptual over literal equivalence throughout the process and using simple language.
And how did the structure of your study differ from the World Health Organization guidelines?
Overall, the differences that we implemented were changes that optimized the feasibility of our approach. So we limited the number of bilingual expert panelists with a goal of 2 each per language. We also limited the number of piloting participants, a goal of 2 per language again. And then we did eliminate that back translation step. So that step can be timely, expensive, and has actually been shown to have limited utility, with some concerns that it can be overly literal and negatively impact the ultimate readability of the materials. And compared to other work in general in this area, We did translate into multiple languages simultaneously. So we had 8 total target languages, which did make the process more complex and nuanced compared to just one target language.
And when you did this, what were some key themes that you felt were really needed for a successful translation process?
We identified 4 key themes overall. So the first is tailoring the scope of your project to your timeline, budget, and resources. That will depend on the particular project's available budget, resources, etc. And so you can make decisions based on your number of target languages, number of expert panelists, etc., based on the specific project. Our second theme is thoughtfully designing source materials. In this case, our source language was English. This will allow research groups to avoid downstream difficulties in the translation process. So some ideas that promote this concept are using universal health literacy precautions, such as simple language when initially designing your English source materials, which then allows for an easier downstream translation. Also, avoiding any difficult to understand words or phrases, or adding clarification, in particular for pre-validated materials that you may be translating that use difficult to understand words or phrases. Our third theme was identifying and applying guiding principles throughout the translation process. Again, this is going to be specific to each research group, but we do recommend that each research group identifies what goals are important to their project and then apply these when they're making translation decisions. So, for example, in a project that has goals of inclusivity and feasibility for their project overall, they may have to weigh these when deciding how many demographic categories to include on a survey. And then our fourth theme was carefully reviewing formatting when translating into multiple languages. So each language is going to have its own characteristics like alphabet, directionality, text expansion, which is the amount of physical space that text takes up. And so when translating into multiple languages, you have to pay attention to each of these aspects for each language, especially if you have both print and electronic materials. So reviewing formatting and ensuring version control is particularly important.
So for researchers who would like to extend their work into other languages and cultures, do you have a sense of what kind of resources they're going to need to expand in terms of time and money?
That will depend on the scope of the project, the number of languages that you're translating into, which languages you've chosen. In our project, our charges were 16 cents to 29 cents per word, which is a little bit hard to conceptualize, but ultimately cost about $200 to $1,000 per document, depending on the language and complexity. Overall, our costs were under $2,000 per language for a set of fairly complex research materials, including several surveys and brochures. And it did take us 6 months additional for our translations to be completed on top of the regular study timeline. So overall, for a fairly complex process is a relatively resource and time efficient process. We do think that it's possible to make this process even simpler, even more time and cost efficient. So we do advocate for generating a national consortium of expert panelists, as well as a shared translated materials library that researchers could draw upon in the future to facilitate economy of scale, make these processes even more accessible and more streamlined. And the other idea that is interesting right now is the concept of artificial intelligence. I think there is a potential promising role for AI in translation methods. However, importantly, this would still require multi-step review to ensure accuracy, as well as review with a population representative of the target population to ensure you're still getting that contribution from native speakers with their lived experience.
And for any researchers who still may feel daunted by these investments, what advice do you have to ensure that they are recruiting diverse patient populations for their research?
One piece of advice I have would be working closely with your language services department to support interpretation during recruitment and piloting to make sure you have the resources necessary. Also, if feasible and consistent with your study goals, thinking about a multi-site study, if that's a possibility for you, to allow for broader geographic representation, potentially partnering with community organizations and community members like community health workers, which can then increase community involvement, collaboration in the research process, and lead to better recruitment of expert panelists and potentially patients as well. And then in general, just thinking about good communication practices, including being transparent and authentic with the patients that you're recruiting, approaching the conversation with a curious rather than judgmental approach, using trauma-informed communication practices can help your recruitment in general.
So do you have any last takeaways for our listeners who'd want to reference and use your methodology when they design these studies?
I think the biggest thing to realize is that the exclusion of patients and families who speak languages other than English from research exacerbates inequities that have been well demonstrated and even violates the Belmont principle of justice, which is that research subjects should be selected fairly and risks and benefits from research be distributed equally. So we, as an overall pediatric research community, need to do better in including these families who use languages other than English equitably in our research. We think that this could be accomplished through increased collaboration, sharing translated materials, establishing that national consortium of expert panelists that I mentioned, having longitudinal relationships with translation vendors, and even stipulations that research be conducted in multiple languages from funding agencies to accomplish broader inclusion overall.
Those are some great takeaways. And Dr. Alyssa Coffin, thank you so much for joining us today.
Thank you for having me.
To read the paper, Creating Culturally Adapted Multilingual Tools for Research, visit our website, aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
So mine is a little somber because we are going up to Colorado this week and we're going to be with all of Christy's family, which is great. But we're going to spread the ashes of her stepfather who died back in October. He has a special place by the Platte River that he requested we go. So I imagine it is going to be a reflective moment. But having been to Colorado in the summer, also maybe appropriately beautiful.
Well, and it's a nice way to celebrate someone's life by taking them to where they really love to be.
Exactly. So he's going to share that place with us posthumously.
I will make my Say about a baby just to counter that, which will be baby fun. Zelda. And that's that we just took her to the beach for the first time.
Zelda, so beach girl.
Yeah, a lot of like moving her to the shade. And no in the sand yet because I don't trust her because she puts everything in her mouth. But I do think she had a good time because she was with her cousins.
Oh, that's great. You know, we love a beach. And we love babies. So baby plus beach,
winner.
Just the best.
Yeah.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll get a research roundup from the July issue of Pediatrics.
We'll also talk to Dr. Lisa Abwogi about infant feeding for people with HIV. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.